Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to JVRD's Author Forum podcast. I'm joined by Dr. Ivana K from the Mass Eye and Ear Infirmary in Boston, Massachusetts. She is the co-director of the Ocular Oncology Service at the Harvard Medical School. We're going to discuss a fascinating manuscript that looked at the impact of confirmatory cytopathology and its potential to alter or improve predictive value of gene expression profiling testing, something I think many of us have been very interested to hear from Ivana and her team. Dr. Kim, welcome.
Thank you. Glad to be here.
It's good to have you here. So you wrote what I thought was a fascinating paper with your team. Could you take me a little bit through what brought the thought process together to look at this review?
There's a paradigm right now where anytime you do sampling of tissues for molecular tests that are fast advancing in our field, that somehow you need a confirmatory cytopathology or some kind of tissue diagnosis along with the molecular testing. I think our molecular diagnostic capabilities have outstripped the sensitivity of cytopathology. So we wanted to look at this to see whether it was essential to have a positive cytopathology result to have faith in our molecular diagnostic results, or whether we could have faith that even in the absence of cytopathology, the molecular diagnostics could give valuable information.
I think our field in ocular oncology has always been a little bit unique, that we were able to make clinical decisions absent of cytopathology, often because our specimens were so small that cytopathology was ineffective. For me, when GEP or gene expression profiling became available, that was a game changer because of how successful that test was in evaluating the profile of the tumor that we were looking at. What was your experience? So before this, were you doing both always, where you were doing cytopathology and GEP, or were you doing just GEP?
Technically, we didn't do a lot of biopsies before GEP was available because we just didn't think that the sensitivity of cytopathology was additive enough to our clinical diagnostic capabilities. But once GEP was available and it was a game changer for prognosis, then we started doing it. And in the beginning, I think some of the pressure to do cytopathology also came from some requirements from payers to have a confirmatory tissue diagnosis in order to cover the test. So we were doing it together most of the time, but then we realized that for the smallest tumors, many times there was a non-diagnostic result. And we wanted to try to show that even in that setting, the GEP result was valuable.
So did you find, so I understand that you found good correlation, but did you find there was a tumor cutoff where the size really wasn't amenable to the suggestion of an effective cytopathologic specimen and review?
I think in our overall cohort, the median tumor thickness was around 3 millimeters. In the cohort without diagnostic cytopathology, it was closer to 2. And we're doing just fine needle aspiration biopsies. These aren't cutter-based biopsies. So I think it's important to recognize the technique as well.
So I think that's fascinating because there has been some discussion, as you know, that we cannot adequately biopsy small tumors, but at least for multi-pass fine needle aspiration biopsy in a small melanoma, GEP is accurate in almost 98.5% of the specimens that we've biopsied, and you had a very high success rate also, correct?
Yeah, I think our rate of GP testing result was very similar to yours in the very high 90s, even in the smallest tumors.
And I think that's a game changer because I must admit at first I thought small tumors may not be as adequately sampled in that we would get, failure to amplify or a non-diagnostic GEP sample, but that turns out to be incredibly rare.
Yes. But I think that's the point is that in that subset of tumors, when you can't get cytopathology, you still can get an answer from GP. In lesions that you know pretty well clinically are melanoma. I think that's the other caveat is that we're not advocating to use GEP as a diagnostic tool to differentiate between melanocytic and non-melanocytic tumors.
That's an important point also because really GEP was developed to be used in the setting of clinically diagnosed melanoma. It's
Mhm.
not a diagnostic test, it's a prognostic test
Yes.
for us. So I
Mm.
find that true. There's been some discussion about doing GEP testing and then not definitively treating a tumor. Does that play a role in your clinical practice?
Currently, we haven't adopted that approach. I know more and more people are inclined to do that, and I think we need to have longer term follow-up about what the natural history of untreated class 1 GEP tumors are. Now that we have PRAME in addition, so class 1 PRAME negative tumors, many people may be inclined not to treat these, but I think we need to know the natural history because all of the prognostic data are based on definitive treatment.
And I think that's also one of those important caveats where when you start to apply a test or a treatment outside of the parameters, you can't use historical data to drive that expectation. So I'm like you, I'm very leery of cytopathology or GEP in the absence of treatment. I always treat if I'm doing GEP because to me, you've already made the clinical diagnosis of melanoma, which has driven you to the GEP testing. So it'll be interesting to see how that plays out over time.
Yeah, and I would encourage everybody who is doing this to, publish results so we have data about how these patients do.
Well, it's going to be interesting too. I think you participated in the reevaluation of the next data set for GEP classification, and that changed fairly significantly from our initial data set, correct?
Yeah, so it was the Collaborative Ocular Oncology Group study too. It was recently published in JCO. Um, I think that the main difference was that we showed that the PRAME marker is more significant, a more driver of kind of the small versus intermediate risk prognostic category versus the older 1A, 1B um, classification. So I mean, I think it's similar. We're just using a different marker now. We're doing, PRAME versus the previous paradigm of 1A, 1B.
So, but bringing us back to your paper, I really think this was elegantly done to show that you could do both of these tests, but you didn't need to do both of these tests. And especially as tumors became smaller, you were more effective with the clinical diagnosis of melanoma doing GEP.
Yes, I think it's particularly helpful for people in centers where they may not have access to a very expert cytopathologist who feels comfortable making a call on the tiniest samples to be justified in perhaps not even doing a second pass in these extremely thin macular tumors. Um, I don't think we have to take the risk of added visual morbidity if we know that just the GEP is sufficient.
And the other thing, I think, if you're doing just GEP and not looking for cytopathology, then that multipass fine needle aspiration biopsy is very effective for that. And I believe it's slightly lower risk overall than cutter-related biopsy. Do you have any feelings on that?
I mean, I think we do cutter biopsies occasionally when we're trying to make a diagnosis, when we want to look at melanoma versus a non-melanoma and we need a lot of tissue. I don't really see the need if we're just doing a biopsy for molecular prognostication in melanoma to get a ton of tissue because, the yield is so good with GEP just from a fine needle aspirate. I don't think we have to be extremely aggressive about the biopsies in these cases.
Dr. Kim, thanks for talking to us. Excellent presentation. For our listeners, the full manuscript's available at JVRD, and we'll look forward to having Dr. Kim join us again. Thank you. Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD forum on the ASRS website to learn more. See you soon.